Welcome to this series of videos on communicating with chronic pain patients. This is Module 7, Explaining Pain Science in Plain Language. Have you ever explained something to a patient, watched them nod their head and thought, they totally understand? Then 2 minutes later, they ask a question that makes you realize they didn't understand at all. As healthcare providers, we spend years learning medical terminology: degeneration, central sensitization, nociception, neuroplasticity, peripheral sensitization. But our patients didn't go to medical school. And when we're communicating about chronic pain, simply giving patients accurate information isn't enough. We need to make that information understandable. Because if patients don't understand our explanation, they'll create their own. And sometimes that explanation is much scarier than reality. Remember something we discussed earlier in this course. Before you explain pain, find out what the patient already believes about their pain. Ask, what do you think is happening in your body when you experience pain? You might be surprised by the answer. A patient may say, my discs are basically gone. My bones are rubbing together. My back is unstable. There's a nerve being crushed. Every time I feel pain, I'm causing more damage. These beliefs matter because they influence behavior. If I believe my back is unstable, I'm probably going to protect it. If I believe bending damages my discs, I'm probably going to avoid bending. And if I believe pain always means injury, every increase in pain becomes evidence that something is wrong. So before giving the patient a new explanation, understand the explanation they already have. Here's a common mistake with pain education. We learn about the nervous system and get excited. So we tell the patient, your central nervous system has become sensitized because of neuroplastic changes that have altered nociceptive processing. Scientifically impressive. Clinically, maybe not. The patient may be sitting there thinking, so, is my back damaged or not? Pain neuroscience education should not be a neuroscience lecture. The goal isn't for the patient to pass an exam. The goal is to give them an explanation that helps them make sense of their experience. Research increasingly supports this idea. A 2026 qualitative systematic review examined how patients and healthcare providers experience pain neuroscience education. One of the findings was that basic teaching principles matter: plain messages, metaphors, repetition, and making the information personally relevant. In other words, don't try to sound smart, try to be understood. Instead of starting with neuroscience, start with something the patient already recognizes. You might say, have you ever noticed that your pain can be worse on some days even though you didn't injure yourself again? The patient says, absolutely. Now you have an opening. You might say, that's one of the interesting things about persistent pain. The amount of pain we experience isn't determined only by what's happening in the tissues. The nervous system also plays an important role in how strongly we experience those signals. Now, the explanation connects to something the patient has actually experienced. You're not giving them a lecture. You're helping them make sense of their own symptoms. One metaphor commonly used in pain education is an alarm system. You might explain, pain is a little like an alarm system. Its job is to protect you when your brain believes your body may be in danger. If you sprain your ankle, that alarm is useful. It encourages you to protect the area while it heals. But sometimes an alarm system can become more sensitive. Think about a smoke detector. You want it to go off when there's a fire. But imagine if it started going off every time you made toast. The alarm is real. The sound is real. But the alarm doesn't necessarily tell you how much damage is occurring. Persistent pain can sometimes work similarly. The nervous system may become more protective and responsive. And this is where we have to be careful. We don't want the patient to hear, your pain isn't real. So I would immediately add, that doesn't mean your pain is imaginary. The pain is absolutely real. What it means is that pain can be influenced by more than tissue damage alone. That's a critical distinction. One of the fastest ways to lose a chronic pain patient is to make them believe you're saying it's all in your head. Patients may have spent years trying to convince people that their pain is real. So when we start talking about the brain, emotions, stress, sleep, or the nervous system, they may become defensive. That's understandable. Instead of saying your stress is causing your pain, try, pain is influenced by many different things. Tissue health is one piece, but sleep, stress, previous experiences, fear, activity, and the nervous system can also influence how sensitive that alarm system becomes. Notice the difference. We're not replacing a biological explanation with a psychological explanation. We're expanding the explanation. That's the biopsychosocial model. Pain neuroscience education has been studied extensively. A 2025 umbrella review brought together 19 systematic reviews involving roughly 5,200 people with chronic, nonspecific low back pain. The researchers found that pain neuroscience education could reduce pain, particularly when it was combined with physical therapy, exercise, or broader biopsychosocial interventions. Other research has found potential improvements in factors such as fear of movement and pain catastrophizing. But here's the important message. Education isn't the entire treatment. We're not trying to talk someone out of pain. We're using education to give the patient a framework that may make movement and rehabilitation feel safer and more understandable. Suppose you're treating someone who stopped gardening because bending increases their back pain. You could spend 10 minutes explaining sensitization, or you could say, "Remember when you told me that bending hurts, so you've been avoiding gardening?" The patient says yes. Then, "One thing I'd like us to work toward is helping your nervous system become more comfortable with bending again. We can start gradually and see how your body responds." Now, pain science has a purpose. We're connecting the explanation directly to something the patient values. Remember, the patient probably doesn't care whether they can define neuroplasticity. They care whether they can garden again. There's one final step we often forget. We explain something and ask, "Do you understand?" And what does almost every patient say? "Yes." Try something different. Ask, "Just so I know whether I explained that clearly, how would you describe what we just talked about in your own words?" Now you're checking understanding without testing the patient. And if they say, "So basically, you're saying the pain isn't real?" That's incredibly valuable, because now you can correct the misunderstanding immediately. You might respond, "Actually, I'm glad you said that, because that's not what I mean at all. Your pain is absolutely real. What I'm saying is that the amount of pain you feel doesn't always tell us exactly how much tissue damage is present." That's communication. When you're explaining chronic pain, remember 4 things. Ask first. Find out what the patient currently believes. Keep it simple. Use plain language and avoid unnecessary medical terminology. Make it personal. Connect the explanation to something the patient actually experiences or wants to do. And finally, check understanding. Don't assume that because you explain something, the patient understood it the way you intended. Pain education isn't about showing patients how much we know about neuroscience. It's about helping patients develop an explanation for their pain that is accurate, understandable, less threatening, and most importantly, useful. So before you say central sensitization, ask yourself, is there a simpler way to explain this? Before you give a 10-minute lecture, ask, how does this information help this particular patient? And after you explain it, ask, what did they actually hear? Because the goal of patient education isn't simply to provide information, the goal is to create understanding. And sometimes the best evidence that you truly understand something isn't that you can explain it using complicated terminology. It's that you can explain it without it.